All right. So I'm taking a slightly different tack than Dan, focusing on what I would be thinking as a clinician sitting in the reading room. And first thing we think about are patterns of injury to try to give us some idea of the mechanism that led to the injury. So we first, in the neonates, when we're thinking about ischemia, we look for central patterns with the ventrolateral thalamus and corticospinal tract involved to suggest that maybe it was a lack of blood flow and oxygen, similar to a cardiac arrest that might have given rise to the injury. If it's more peripherally and dispersed without the central involvement, there's many different mechanisms we don't quite understand, so it's a little more vague. And then we have the focal arterial strokes where the rest of the brain is normal, and there's just one isolated or multiple lesions in a vascular territory. We can get ischemic injuries on the venous side as well. Sometimes we just get venous edema. Sometimes there's venous hemorrhage. But occasionally we'll see some subcortical ischemic necrosis from a venous side, so either from the arterial or venous are the patterns of ischemic injury we see. But as a radiologist, one of the first things you have to make sure is that there is a differential diagnosis and we're sure we get the right diagnosis. So to begin with, we're going to talk about central patterns, and I'm going to focus mostly on that as an example. This is one of the things we know most about because there's typically a sentinel event associated with it. So often the kids are born with very low APGARs. So as APGAR 0 means there's no respiratory rate, there's no heart rate, and the child's blue. So basically they're arrested, they're essentially dead on the table. So it's a cardiac arrest. And that's the pattern we see. Again, these ventrolateral thalamus, posterior limb internal capsule are typically what are involved. pH can be low, especially if it's been persisting for a long time, and it's quite common that they present with seizures within 12 hours. To have the full hypoxic ischemic encephalopathy definition, you need other organs involved, but often we'll see imaging patterns of these profound, deep injuries, even without sometimes other organ involvement. So this is the most common pattern we see when there is encephalopathy or hypoxic ischemic encephalopathy. That's often you can identify sentinel event. Injury occurs to areas of high metabolic demand where there's high concentration of excitatory amino acids, NMDA receptors, and active myelination. And again, the most common areas are the VL thalamus and corticospinal tract, but it can expand to involve other areas like the perilymphatic cortex, hippocampus, lateral geniculate, mesencephalon, and posterior brainstem, areas that are actively myelinating. And as I said, the hypoxic ischemic encephalopathy is a clinical definition. Many of these kids have it with profound metabolic or mixed acidemia, 1 in 5 minute APGAR scores, 0 to 3, neurological manifestations, and multisystem organ dysfunction. This has become the classic definition of HIE, and often to start treatment, they have to meet many of these criteria. But there's been a growing sort of controversy over who should be treated, when to treat, and do you just take terms that have a risk factor and are encephalopathic and don't require pH or other organ involvement, and can imaging help to determine who should get treatment and who shouldn't? Right now it's all protocol based. Unlike, say, what is emerging in the stroke literature, we don't currently treat neonates based on brain state of injury. We treat based on criteria. And that's become a struggle for the clinicians, particularly the neonatologists who are less familiar with imaging. They don't trust it as much, so it's often done in protocol. Some groups are reluctant to go off protocol and treat kids outside the strict criteria, and other groups are much more aggressive. So there is no consensus over who should and shouldn't be treated. So coming from a radiological perspective, I think first when we see something like that, you have to back up and say, is it first normal or abnormal, the imaging? And if it is abnormal, is there a differential I need to consider? Because before we start cooling everybody that comes across our workflow, we have to make sure, that's kind of our job also as radiologists, is to think broadly and make sure there's not something else going on. If there is ischemia, what's the etiology stage and severity? And can imaging help? So let's first focus on normal or abnormal. And as Dan pointed out, especially in this age of cooling, this is not an easy task. I've got a collection of 6 children up here. 1 is normal, 1 died, 1 had a severe outcome, and 1 has mild motor delay. Similar clinical presentations, all we image them on cooling, so these are at 3 to 4 days, each of these MRIs. And as you can see, it's really hard. There's one that's a little more grossly abnormal down here. The problem is we're looking for abnormalities in the ventrolateral thalamus, which is normally a little dark. So it's a little bit darker here on the T2 and on the ADC maps because there's more myelin there. So we're at a disadvantage compared to adults where you have a homogeneous ADC map and you're looking for the one area that is different from a homogeneous background. Normally the ventrolateral thalamus and corticospinal tract are darker because they're more myelinated. So how low is too low? And what we've been doing to date is relying on our experience and our visual perception. But my problem is, even though I've been doing this for many, many years, unfortunately now, what I call normal probably is related to what I read the scan before. Our ability to call normal drifts depending on what we see that day. So it's a very challenging task. And so there's a lot of variability in our reads as a result of that. So these are the children. This one was a normal, and this child here, you can see there's some subtle abnormalities that you see showing up on the ADC map. Ventrolateral thalamus, corticospinal tract, lateral putamen, and beta globus pallidus. This child has some mild motor delay at about 1.5 years. This child died, and this child did not have care withdrawn and is currently microcephalic, severe developmental delays, and spasticity. So both of these had poor outcomes. We know what hypothermia does do is decrease the numbers that have these very severe outcomes, but it doesn't really, we don't really have the data yet to know how much it helps with the cognitive disabilities. So I think one challenge that we face as radiologists now is calling normal versus abnormal, particularly in the age of cooling. So this is where we get to big data, and this is a grant that we have right now in collaboration with Sean Murphy, who's an informatics person at MGH, and Randy Gollop, who does a lot of image analysis at MGH. We have a multi-site grant with Brigham, us, and MGH to mine our clinical databases, because in our databases we have hundreds and hundreds of ADC maps and T1 weighted images. And what Steve Piper did, who's from the Slicer group who collaborates with as well, made a little montage of the hundreds of data sets that we have. So these are all, this mosaic is made up of individual MRI scans of what we've gathered. So we're gathering all this data, and we use the informatics system to try to mine through and find out who has been followed up and clinically diagnosed as normal, and we pull aside all those normals to try to create maps. And this is just the first data that has been submitted to human brain mapping. I think it'll be presented at, where we have 86 subjects so far that are normative, at least, and the 0 to 1, and total of 301 in total. So this is expanding. This is the first round we did from the MGH database. We're now moving into the children's database to gather more there, to create these templates of normal maps. And these will be eventually posted on this interactive website here. Right now, all we have are volumetric T1s at birth, 1 year, 6 months and 1 year that are normal, but it's going to have layered in there template maps plus multiple individual maps, so that the goal is to come up with a clinical assist. As you're reading your scans, you can pull up a website, and instead of a paper where they put 1 or 2 voxels and they publish graphs of mean data, you'll be able to interact with the data set, put your cursor where you're looking, and see what the mean data is for the b-values that we use, which are going to be a b-value 1,000, to collect these data sets. And I think this kind of sharing and standardization and databasing is something that we need to do more often to create these normative databases and start to get us towards a quantitative imaging that Dan was asking for, because unless we leverage what we normally see, we'll never get enough NIH funding to create those normal databases and maintain them at the quality that we're currently imaging. Because up to date, all those normative studies, at the end of the 5 years, they fix the protocol, so it ends up being obsolete by the time the data set is done. So the goal is to create a continually renewing database of normal studies as we move forward in time. Another point just to make in terms of, as we said, the database, chose a b-value of 1,000, and that's because it's standard across both adult sites. Some people have asked me, well, why don't you use lower b-values such as 700 or 500, because that's supposed to be better data for neonates. And it depends what you want to do with the data. When you get a lower b-value, you can shorten your TE, so your SNR is higher. So lower b-values are better at quantitating accurately high diffusion and for improving maybe your tractography results. But the goal first of our clinical database is to detect abnormalities. So if a higher b-value is used, you have more conspicuity to detect areas of decreased diffusion. So that's why we chose 1,000. If you go to higher values such as 1,500, some of these areas stand out a little bit more, because as you increase b-value, you're weighting your image more towards the ADC map, so it starts to match more the ADC map. So it's a little, you could go to higher, but since B1000 is a pretty ubiquitous and standard and has been for many years, that's a value that we've chosen to do our studies. Another thing that Dan brought up too is the time issue. I collaborate a lot with the Martino Center, and so if they want to understand, say, tractography, they'll just put someone in the scanner for an hour or 2 hours. And if we're running a clinical study, I can't ask what's the optimal scan to do. My question is, what's the optimal scan I can do in 5 minutes? Because I've got 5 minutes, and I just got to know how I can spend it best. So what we started to use now is a new sequence that just came out from the Charlestown group, Cowan's double slice acquisition SMS diffusion, so simultaneous multi-slice diffusion. And we've benchmarked it against our standard diffusion, and we found that compared to a normal acquisition, actually we're running with 30 directions at about 5 minutes. We've dropped that to a half to about 2.5 minutes. So now I can get 30 direction DTI on everybody in less than 5 minutes and about 2.5. But still, I'm worried that I can't, using the same parameters now, because the ones I showed you that collection were all 30 direction ADC calculations. I think we have to think about other strategies as well, too. So if I can get 35 or 30 directions in 2.5 minutes, maybe I still keep the 5 minutes and start doing other things. So what we're starting to look at is multi-shell approaches. So if we do 2 shells of b-value 1,000 and 2,000, we can start to pull out other characteristics of the diffusion parameters, such as mean square displacement, which is how far away from the initial site the water molecules moved, return to zero probability, which is related to the pore volume or the available space to diffuse in, and mean kurtosis. And if you're going to ASNR after this, you'll find out that kurtosis is a big theme in terms of detecting brain injury in the adult population. I wasn't able to find any publications in injury in the neonatal population, but I think it's something we need to look at. Maybe kurtosis will help me differentiate myelinated areas from injured myelinating areas, and I don't know yet, but we do need more data or more information about the characteristics of the diffusion, so I'm hoping that we can leverage the speed to get more information that might help in the future. So now we decide it's abnormal. Is there a differential diagnosis, or is there more than one diagnosis? And when you're doing research, it's easy to just look at one diagnosis when it's been already categorized. But when you stand back and see what happens in real life in the reading room, we can get, these are 6 different patients that can show up with very similar histories of acute onset of seizures, may or may not have the Apgar scores to go with it. And your job is to decide what are the potential diagnoses to be considered. One of these is hypoxic ischemic injury. The rest are other abnormalities. This one here was one of the ones I showed from the collection before with a fairly profound hypoxic ischemic event with low Apgars. Standard ventrolateral thalamus, lateral putamen. You see a bit of optic radiations involved as well. Not infrequently we'll see lactate, and actually more often now in the cooling stage we see a little lactate even when there isn't diffusion abnormalities. But you need to think about herpes encephalitis. It can present very similarly. It can have bilateral involvement, it can have basal ganglia involvement, so it can mimic either these cardiac arrest type patterns, or it can mimic the partial patterns, it can mimic stroke. So always think about that and make sure there's no clinical indications. This pattern fits with hypoxic ischemic encephalopathy. We see VL and some corticospinal tract, What is helpful here is this massive lactate peak. When I see a massive lactate peak in a pattern that's similar to hypoxic ischemic injury, you think about vulnerability. Maybe this child had a pre-existing vulnerability and though had very bad APGARs and presented exactly like HIE as an underlying diagnosis. So think about that when you have a pattern that fits with HIE, but no prenatal history that leads up to it, and very large lactate peak. Or another hint is a corpus callosum that is incompletely formed, because many of the metabolic abnormalities can have partial agenesis of the corpus callosum. This child arrested afterwards, and just to point out that this is a child with a congenital heart disease, that the patterns we do see with HIE are very similar to cardiac arrest, because they're essentially the same thing but happen for different reasons. These are two metabolic disorders showing that when we do see metabolic disorders, often the involvement of the basal ganglia is slightly different. This is a urea cycle disorder. We don't see the areas of vulnerability of ventrolateral thalamus involved. This is sulfide oxidase deficiency. Again, we see actually relative sparing of the thalamus instead of selective involvement. So if you don't see selective involvement of the ventrolateral thalamus and corticospinal tract, think of metabolic disorders. So you have to keep this in your mind. And just to go on further, because there are lots of things that can mimic it, and if you're in a busy children's hospital, you see these things do come up. We've been using, and I was actually surprised, and the reason I put a lot of spectroscopy in here is I even had in our group, people are saying, well, do we really need that spectroscopy sequence? Can we shorten it? Can we take out the spectroscopy? I find it to be very helpful, and you never know when it's going to be useful until you've already done it. So it's helpful to have it routinely to identify the potential metabolic disorders, in particular the mitochondrial ones, but also these other disorders that can mimic hypoxic ischemic injury. These are all neonates presenting within the first few days of life. Maple syrup urine disease, again, usually at first doesn't present with a low APGARs and has a particular specific urine smell. But think of that when you see the diffuse basal ganglia involvement, and branched chain amino acids can be seen on the spectroscopy. Non-cutaneous hyperglycemia can mimic very closely hypoxic ischemic injury. Again, typically there's more posterior fossa involvement, and characteristic is this glycine peak at 3.5 ppm that persists even at 144 milliseconds. So if this was myoinositol, it would have decreased at the long echo time. Canavan's disease can also present within the first week of life, occasionally with low diffusion, and the hint there is the high NAA peak compared to what is normal at all echo times. I'm showing here echo time of 144. So my main point here is I think MR spectroscopy is critical in terms of triaging our infants. It hasn't been that popular, and I think there are improvements that are going to change that. We were presented last year by one of our fellows, Sandrine, is our accelerated 3D Spiral CSI. It's a 3-minute acquisition, so the same amount of time as a single voxel. It used to be these 3D volumes took 20 minutes, so they were impractical to do in any kind of clinical workflow. Right now we're doing a 2 cc voxel size. You can see equivalent signal to noise, but we get an entire region of the brain with 80 voxels in total. What the advantage of this is, and again, another problem we have with spectroscopy, we don't have normative data. So the data that is in the literature are single voxels from various regions, different echo times. So it's very hard to know whether what's normal and what's abnormal. So these volumetric acquisitions are actually tied to the 3D anatomy of the neonatal brain. So as we start to atlas the brains that I was showing you before, the volumetric T1s and the ADC maps, we can take those volumetric T1s and co-register them, and then co-register the volumetric spectroscopy data to start to create those normative databases and improve our spectroscopy in terms of the precision of our calls. Because I know that at least I am still way undercalling probably what is abnormal, because I don't have good enough normal data to know what the means and standard deviations are in different regions of the brain. But I think it's something that will help triaging, and as I was looking through the cases to make the talk, I was surprised at how many of the ones had normal ADC maps that did have lactate. So I think that this will be helpful in terms of understanding who's at risk, even if they are cooled. And one thing we're pushing too is for more metabolites. Even at 3T, we're starting to get people working on GABA. It's going to be a large voxel, probably hemisphere, maybe whole large centers of brain, but at least we'll be starting to be able to tease apart excitatory and inhibitory amino acids, which might again help in terms of triaging or optimizing treatment therapies. So if we do now identify ischemia, can we say anything about the etiology, stage, or severity? We do know that these injuries evolve over time. This is a case from prior to cooling. So we do know that there is an evolution. And this is the same diagram that Dan showed. It's one of my favorites as well from Donna Ferrero, showing that when you do have the injury, the cell death process continues on for days to weeks. So if we image, we only have one snapshot in time, and much is of a lot of programmed cell death or delayed cell death is happening. What we can say when we do see and run perfusion imaging, for example, and we see this high blood flow, we do know that the environment is ripe for delayed cell death because you need energy to go through delayed cell death mechanisms. So if we do see these hyperperfusion states, we know that they're in a risk for evolving and continuing evolution. Whereas you see a matched low ADC and no blood flow, that's sort of a completed injury, more like acute stroke. The hyperperfusion often exceeds the area of the diffusion abnormality, so it identifies a larger area risk, and it's not unusual to see no lactate in those areas, again indicating that it is not ischemic, immediate necrosis that is dying by lactic acidosis at that time. Can we use imaging to help understand pathophysiology? Well, this is where we got into the near, similar to Dan, is we saw first that with without hypothermia, we saw high blood flow, and then when we cooled them, the blood flow went down, and the label stayed in the vessels and didn't even make it to the cortex. But what actually is happening to the brain is this blood flow due to changes in neuronal demand, due to lack of autoregulation, or is it peripheral cardiac changes? So we went to the bedside as well with our continuous wave frequency domain and DCS systems, focusing on these two to get oxygen metabolism. Because although we're working on sequences in MR, as Dan pointed out, we get just a whole brain measures, and if you're labeling the suprasagittal sinus, you may not get information about the deep gray nuclei. So looking at cases without hypothermia, as Dan showed, what we found is that oxygen consumption was up in those kids. So it suggested that that high blood flow we see is not lack of autoregulation, it's increased end organ demand. So we're having excitotoxic cascades play out with increased neuronal activity. When we cooled them, the oxygen consumption went down. So what was very interesting to us is that cooling is the treatment to decrease neuronal activity. We have a tool at the bedside to identify increased neuronal consumption and a tool to assess response to treatment. So luckily we just got funded to do a multi-site trial to go to the bedside to screen with our NIRS instruments to see if we can identify in the very early stages, because as Dan pointed out, this is later on, around 5 days, the high oxygen consumption. Can we identify it prior to cooling? Can we track the trajectories at the bedside and look at that temporal time course to better predict outcomes? Interesting, the standard NIRS systems that people use showed high oxygen saturation in both. When you have increased neuronal activity, you get increased blood flow to the area of tissue, and flow always exceeds demand. So oxygen saturation goes up. That's the basis of BOLD. So oxygen saturation is up. However, when you cool babies and you drop their neuronal activity, consumption decreases, and therefore oxygen saturation goes up. So we're not a big fan of oxygen saturation alone as a metric, because it can be up when you have opposite effects happening with the neurons. Here's an example of two kids that we also did ASL on. This child that responded, the CMR02 went down. This child that did not respond and ended up having neonatal diabetes. So we're wondering whether NIRS can help stratify, again, who should be treated and if they're treated appropriately, because it wasn't until after the child was cooled that the diagnosis of neonatal diabetes was made. Here's another more peripheral pattern of injury that also had high blood flow in ASL and high oxygen consumption. This child didn't meet entrance criteria. Would these brain metrics of high blood flow and high oxygen consumption be better tools to stratify who should be treated? This child presented a day and a half out. Strokes currently are not treated. They often come with increased blood flow, and this is another child that we showed increased oxygen consumption. So can we use NIRS to individualize care and better stratify who should go to cooling and broaden the criteria with a metric that makes people feel more comfortable? Therapeutic hypothermia does change things. As Dan mentioned, it does change the evolution and timing, so you've got to be very careful using old literature when timing injury. The globular effects of the T1 may not appear till weeks after the injury when they used to appear much earlier, and the T2 weighted findings are sometimes difficult to pick up in the 7 to 10 days it used to be able to detect as well. Also, what is we see in general is that the outcomes in general are better. It's harder to see the abnormalities compared to before. They have minimal, you can see this child here would had no clear abnormality, maybe a little bit low, but is that too low? It shows abnormalities here in follow-up, but was hard to detect on the initial imaging. So the equations have changed, and we need more than just imaging to predict outcomes. And in particular, looking at the literature, we really don't have any good predictors because the MRs are not near the babies. They're often done late, and the only predictors we have is with motor outcome, and we've done some same tractography and shown correlations with outcomes that we haven't published yet, but that's basically all the data is that we can correlate diffusion in corticospinal tract areas with outcomes, and those correlate with cognitive outcomes because usually it's a global hit. Same thing is coming along with some of the cardiac outcomes. Can we use MR to determine when to withdraw care? No, not yet. We don't have the data to do it. Why not? We don't have the bedside, the imaging at the bedside. These kids are too sick to bring them to the scan when the decisions need to be made. So can we change the equation? Transport isolates can get the baby to the scanner maybe more effectively and comfortably, but can we bring the MRI to the baby? And this is a project that we're working on with GE to site an MRI within the NICU. Cincinnati has done that with 1.5T. We'll do it with 3T and with GE, and maybe that will help us achieve the goal. We're hoping that will change the equation and get MR up front in that acute time period so we can start to see whether we can use MR to modify or to determine what treatment should be and better diagnose. But MR alone will probably not be enough. It only sees certain aspects of what's going on. I think we'll always be using complementary NIRS systems, and Canon is starting to commercialize these. Dan and I are both involved in that venture, so hopefully there'll be some devices that are not so cumbersome and require a couple of postdocs in order to be able to actually do them. This provides really relevant optical information. We also need to have neural activity information, because whether the neurons are seizing and where the seizures are coming from and how the connectivity is changing over time is going to be partially governed by neural activity as well. EEG doesn't work well in preterms or in terms because of the changing soft tissue swelling and changing suture size. MEG does not have those issues. So we're developing a baby MEG system that will be cited later this year and hopefully will be picked up by commercial ventures as well too, to be able to allow us to better understand neural activity. And finally, one of my last slides, I think it is the last slide, PET, I think, is going to be coming back on the table. No matter what we do with MRI, NIRS, and our EEG, MEG systems, they're non-specific. And treatments are molecularly based. There are new scanners, PET scanners coming out that have small bores, and similar to MRI and MEG, if you get those detectors closer to the organ, then you need less doses. And in these new systems that are coming along, the effective dose are picomolar concentration, so it ends up being less than 1 millisievert, so less than what most CTs are. And I think that can be pushed probably a little bit more. Once we're in that minimal risk, as long as there's a potential for gain, I think things might start happening in this area again. So I think keep an eye out for this. This is a system that's been developed at MGH. We've been approached by another vendor to think about some technology advancement in this area, and I think it's a really interesting thing to shrink the size of these PET cameras to use in our babies so we can significantly decrease the doses. So I'm going to stop there. We started out with sort of a pattern-based approach to imaging. Think about differential diagnosis. Think of all the imaging we have at hand. I totally agree with Dan's comments about prenatal imaging. We're also working very hard in that area and have gotten recently funding to develop sequences to do flow and other metrics with placenta and fetus. So this is all pushing back not just into the newborn, but into the fetal prenatal stage, because we all recognize that prevention is better than cure. So we want to be able to prevent the hypoxic ischemic injury from happening, and to do that we have to go to prior to the event. Thank you.